How's it going, guys? Past level question, hematology, pathology, step 1, 24-year-old male, no past medical history, physical exam shows vitiligo on the hands, does not adhere to any specific dietary regimens. Question wants to know what's most likely to be seen as patient. Choice A, abnormal D-xylose test, wrong fucking answer. D-xylose is a monosaccharide that does not require any enzymes for absorption. If we can successfully detect it in the blood, which means we have a normal D-xylose test, it means our intestinal lining is intact and there's no abnormality with the architecture of the intestinal lining. This could refer to lactase deficiency, where although we have disaccharidase deficiency at the brush border, the villi themselves, the intestinal lining itself, has no abnormality. It could indicate exocrine pancreatic insufficiency, such as with chronic pancreatitis and alcoholic. It could be cystic fibrosis. In contrast, if we have an abnormal D-xylose test where we can't detect it in the blood, it means we have abnormal intestinal architecture. Could indicate celiac disease, where you have flattening / blunting in the intestinal villi. Could indicate Crohn's disease. I'll talk about the diagnosis as we move through this clip, but in this case, we have normal intestinal architecture, hence choice A, wrong fucking answer. Choice B, antibodies against gastric chief cells, wrong fucking answer. So chief cells secrete pepsinogen, a zymogen, inactive enzyme that in the increased acidity of the stomach is going to be cleaved into active pepsin, which breaks down protein. Choice B, wrong fucking answer. Choice C, decreased spinal thalamic tract function, wrong fucking answer. Diagnosis is, well, actually, why don't I just keep leading up to it? Be a fucking asshole, right? So in this image, we're looking at a hypersegmented neutrophil. These can be seen in either B9 folate or B12 deficiencies. Now, in the vignette here, OMG, I wrote patient has vitiligo, and I've harped on this in my PDFs and prior YouTube clips that USMLE is obsessed with autoimmune diseases going together. You don't have to worry about specific HLA associations. I could have said type 1 diabetes. I could have said he has SLE. I could have said his brother has rheumatoid arthritis. The implication here is, since he has one autoimmune disease, he probably has another, which could be pernicious anemia. So pernicious anemia is a type 2 hypersensitivity where we have antibodies against gastric parietal cells, not chief cells. So parietal cells secrete not just hydrochloric acid, but also intrinsic factor, which is required for B12 absorption in the terminal ileum. Now, for decreased spinal thalamic tract function, the reason it's wrong is because the neuropathy that you sometimes get in B12 deficiency, it's not in all vignettes. Some students get flummoxed over this point. They don't have to give you neuropathy, okay? So if you have neuropathy in B12 deficiency, which we call subacute combined degeneration, the 3 tracks that are involved, the way you remember this is by first stating to yourself, the spinal thalamic tract is not involved. Now that you say that, you then say to yourself, well, what tracts do I even know of? I know of the corticospinal tract. Okay, that's involved. I know of the dorsal columns. Okay, those are involved. And then the spinocerebellar tract, a bit more obscure, but those are the 3 that are involved. Spinal thalamic tract, normally for pain and temperature. If you have a lesion, you're going to have loss of pain and temperature contralaterally. And if you have bilateral loss, it's called syringomelia, where you have a lesion at the anterior white commissure, usually due to a serrance. Choice C, wrong fucking answer. Choice D, increased serum homocysteine, correct answer. So a bit easier actually, because serum homocysteine is increased in both B9 and B12 deficiencies. So some of you who are a bit iffy on that point, you didn't know the specifics of methylmalonyl-CoA / methylmalonic acid and homocysteine, you could have gotten by because increased in both B9 and B12 deficiencies. It's a pass-fail exam now. You don't have to worry about the obscure biochemistry. But once again, in both folate and B12 deficiencies, you're going to have increased serum homocysteine. Okay? However, only in B12 deficiency are you also going to have increased methylmalonic acid / increased methylmalonyl-CoA. So I'm going to summarize this real quick. It's an up arrow for both homocysteine and methylmalonyl-CoA / methylmalonic acid in B12 deficiency, but only in B9 deficiency we have just increased homocysteine. Methylmalonic acid is normal. Choice C, wrong fucking answer. You know the deal. To make more content, if you like my stuff, subscribe my channel. Appreciate your time. That's it.